We have just a monumental stack of material on the table today, and the mission of this deep dive is to really synthesize it into something you can actually use.
Yeah, there's a lot here. It's dense.
It is incredibly dense. I mean, we are pulling from this vast array of clinical guidelines,
Mm.
psychiatric research papers, Johns Hopkins Rapid Protocol, and just decades of historical data on trauma.
Right.
So we're essentially exploring the front lines of the human mind in crisis.
Mm.
And whether we're talking about an acute disaster, a chronic mental health struggle, or the immediate, terrifying risk of self-harm, the overarching question is really,
How do we actually support others without, making things worse?
exactly, making it worse is the big fear. So by the end of this conversation, the goal is to equip you with the actual tools of psychological first aid, crisis intervention, and suicide prevention.
It's a heavy stack of sources, like you said, but it's an incredibly empowering one, I think. We're taking these concepts that are usually, locked away behind medical degrees and translating them into a practical, conceptual toolkit for everyday application.
Right. And to ground all of this, I really want you, the listener, to put yourself in a specific scenario. Just imagine you're watching a friend, a coworker, or even a total stranger experience a sudden, overwhelming psychological crisis.
Which happens more often than people think.
It does. Maybe a localized disaster just struck your community,
Mhm.
or they just received devastating personal news,
Mhm.
and you're standing right there, you want to help, but suddenly you just freeze.
The classic deer in headlights moment.
Exactly. The internal monologue just immediately kicks in. What if I say the wrong thing? What if my attempt to help actually causes more trauma?
And, that hesitation is one of the absolute most common human reactions we see in the literature. Because when confronted with a physical wound, we generally know what to do, or at least we know what we're looking at.
Right. You see blood, you grab a bandage.
Exactly. But a psychological wound is invisible. So without that physical reference point, the fear of doing harm literally paralyzes people. But the overarching theme across all these clinical guidelines we're looking at is that psychological crises are not just random chaotic panic.
They actually follow a structure.
They do. They're highly structured physiological and psychological events. And because they follow these predictable patterns in the brain and the body, they can be met with structured, evidence-based responses.
Which is such a relief.
It is. You do not need to be a clinical psychologist to provide initial critical support. Just like you don't need to be a vascular surgeon to know how to apply pressure to a bleeding wound.
That is such a reassuring place to start this deep dive. But before we get into the actual tactics of how to intervene, we really have to define our terms, because the word crisis gets thrown around constantly in daily life.
Oh, absolutely.
Like, you lose your phone, you miss a flight, people say, oh my gosh, it's a crisis. But looking at the research from the crisis management experts in our stack, they define this much more rigidly.
Yeah, the clinical definition, particularly from researchers like Boyne and Asthart, frames a crisis as an overwhelming event that fundamentally disrupts the normal order of everyday life and threatens a person's core values.
Okay, so it's not just a bad day.
No, not at all. We are talking about events characterized by deep, profound uncertainty and intense time pressure. A divorce, an act of sudden violence, a terminal illness diagnosis, or obviously a large-scale natural disaster.
It's a fundamental severing of how you operate in the world. And the sources point to this concept of resource loss, which I found just fascinating. The researcher Stephen Hopful emphasizes this heavily.
Yeah, Hopful's conservation of resources theory is really foundational to understanding trauma, because in a crisis, people experience the acute loss of things that matter deeply to them. But we have to think about resources very broadly here.
Right? It's not just money or a car.
Exactly. It's physical property, yes, but it's also the loss of a loved one, the loss of a sense of physical safety, or even the loss of one's own identity and daily routine.
It cascades. Like, if a tornado takes someone's house, they obviously lose shelter, but they also lose the family photo albums. They lose the safety of their bedroom. They lose the routine of having, coffee on their front porch.
And the stress isn't just about the building itself. It compounds with every single one of those secondary losses.
It's a domino effect.
Precisely. And even the mere threat of that loss is enough to trigger a severe stress response. And as these losses compound, the psychosocial impact follows a very distinct emotional timeline.
Right, Beverly Raphael's work.
Yes. Beverly Raphael, she's a prominent researcher in disaster psychiatry, and she mapped this trajectory out beautifully. It generally starts with the impact phase.
Which is the immediate shock, right? The adrenaline, the terror, the confusion, right as the event is happening.
Exactly. From there, populations typically move into what Raphael calls the honeymoon phase.
Which, I have to say, sounds completely counterintuitive. A honeymoon after a disaster. I mean, what?
I know, it sounds really strange until you actually look at the sociological behavior following a major event. Think about the days immediately following, say, a massive hurricane or a severe community tragedy.
Okay.
There is this massive influx of social support. Neighbors who have literally never spoken a word to each other are suddenly sharing generators and cooking meals together.
Oh, right. Like first responders are on the scene, charities are handing out supplies.
Exactly. And the media is broadcasting the community's resilience to the world. There's a profound shared sense of survival.
So everyone is bonded by this intense shared experience. But the problem the sources highlight is that this phase has an expiration date.
It always does. The news cameras eventually pack up and leave, the charities have to move on to the next disaster, and when that external support structure inevitably recedes, the community plunges into the most dangerous period, which is the disillusionment phase.
And when does that happen?
Usually weeks or even months later. The adrenaline has completely worn off, and the stark reality of the long-term struggle just sets in. People are left to navigate, insurance claims, rebuild homes, and process their grief entirely in isolation.
Raphael actually refers to this as the second disaster, which is such a chilling phrase.
It is, because the mental health decline during the disillusionment phase is incredibly steep. This is exactly where you see the spikes in clinical depression, severe anxiety disorders, domestic violence, and substance abuse.
So the initial disaster took the physical infrastructure, but the second disaster takes the psychological toll.
Exactly, which perfectly frames why immediate structured intervention is so critical. You are trying to build psychological resilience early on to buffer against that inevitable disillusionment phase.
Okay, so that brings us to the actual concept of psychological first aid, or PFA. And the history of this is surprisingly deep. I mean, physical first aid has been around forever, right?
Yeah, we can trace organized physical first aid all the way back to the Order of St. John in 1048, where they were training lay people to treat battlefield injuries in Jerusalem.
Wow, 1048.
Right. But the modern framework really galvanized in 1859. There was a Swiss businessman named Henry Dunant, and he witnessed the aftermath of the Battle of Solferino.
What happened there?
There were like 40,000 soldiers dead or wounded on the field, and virtually zero medical infrastructure to help them. He was so horrified by what he saw that he organized local villagers to provide basic, nonpartisan medical care.
Just normal people stepping in.
Exactly. And that specific effort led directly to the creation of the International Red Cross.
That's incredible. So we've understood the body and physical triage for centuries. When did the psychiatric community finally realize the mind needed that exact same emergency triage?
That paradigm shift occurred much later, around World War II, and it was catalyzed heavily by a civilian tragedy here in the U.S., the Coconut Grove nightclub fire in Boston in 1942.
That fire is infamous.
It remains one of the deadliest single-building fires in history. I think nearly 500 people perished. And in the aftermath, psychiatrists, notably Eric Lindemann, began extensively studying the survivors and the bereaved families.
And what were they seeing that was different from, normal grief?
Well, they realized that the human mind absolutely has natural defense mechanisms for processing grief and stress. But under continuous, overwhelming assault, like surviving a horrific fire and losing multiple family members simultaneously, those mechanisms simply collapse.
They just break down.
Right? Lindemann and his colleagues recognized that waiting, say, 6 months to get these people into traditional psychoanalysis was a complete failure of care. They needed immediate psychological stabilization right then and there.
And out of this era, heavily influenced by military psychiatry treating combat stress, we get this foundational concept, the PIE principles: proximity, immediacy, and expectancy.
Yes. PIE is really the bedrock of crisis intervention. Proximity dictates that you treat the individual as close to the traumatic event or their usual environment as safely possible.
Instead of taking them away.
Right. Historically, if a soldier had a psychological break, they were shipped far away to a psychiatric ward. But pulling someone entirely out of their social matrix and dropping them into an alien clinical environment often just exacerbated their feelings of alienation and illness.
So you want to keep them tethered to the world they know, and then Immediacy seems pretty straightforward, treating the reaction urgently as soon as the signs of distress manifest, rather than waiting to see if it just gets worse.
The timing is critical there because trauma begins to encode itself in the brain very quickly.
It makes me think of a broken bone. Like if you suffer a compound fracture, you don't hop on a plane and fly across the country to your preferred hospital before doing anything about it.
Definitely not.
Right? If you don't stabilize and set that bone immediately, which is immediacy right near where the accident happened, which is proximity, the bone begins to heal crooked. And fixing a bone that is healed crooked requires re-breaking it, which is vastly more painful and complicated.
That analogy holds up remarkably well to the neurobiology of trauma. You are quite literally trying to splint the psychological fracture before maladaptive neural pathways and, negative coping mechanisms set in.
But the third letter, expectancy, that feels like the most nuanced part of this whole principle. The sources define expectancy as treating the person's reaction not as a permanent pathology, but as a normal, temporary adjustment.
Yeah, expectancy is all about the tone and the framework that the intervener brings to the crisis. Think about it. When someone is experiencing acute trauma, they're shaking uncontrollably, maybe unable to remember their own name, feeling entirely disconnected from reality. Their immediate internal thought is, I am losing my mind. I am permanently broken.
So expectancy is the intervener stepping in and basically saying, you are not broken, this is temporary. But I have to ask, how does just telling someone that actually do anything? Like, does it biologically change what's happening to them in that moment?
It actually does, because it halts the secondary anxiety loop.
Secondary anxiety loop.
Yeah, when a person panics and then they realize they are panicking, they develop anxiety about their anxiety. The brain perceives the panic itself as a new threat, so it dumps even more cortisol into the system.
Oh, wow. It's a feedback loop.
Exactly. So by an authoritative or just a calm presence, setting the expectation, telling them, hey, your heart is racing and you can't focus because your brain is doing exactly what it was evolved to do to survive a threat, it removes the stigma and the mystery from their physical symptoms. You depathologize the moment.
They stop panicking about the panic.
Yeah.
You're essentially framing their chaos for them.
And the longitudinal data proves how incredibly effective this is. There's Zahava Solomon, a brilliant trauma researcher, who conducted a landmark 20-year study tracking Israeli soldiers who experienced severe combat stress during the 1982 Lebanon War.
20 years. That's a massive study.
It is. She compared soldiers who received immediate PIE intervention on the front lines against those who were evacuated and treated later. 2 decades later, the soldiers who received immediate normalized intervention had drastically lower rates of chronic PTSD. The PIE principles fundamentally altered the trajectory of their entire lives.
That is just staggering. Okay, so we have the theory, we have the historical proof that it works. Now we really need to bridge the gap into practice. If I am standing in front of someone whose life has just been turned upside down, what do I actually do with my hands and my words?
Right, the tactical part.
Exactly. The literature leans heavily into this highly structured framework called the Rapport model, which was developed at Johns Hopkins University by George Everly and Jeffrey Litting.
The Rapport model is phenomenal because it's an evidence-informed tactical toolkit. It's designed to meet basic needs, stabilize physical and emotional reactions, mitigate acute distress, and basically facilitate access to continued care. And it is designed specifically so that non-clinicians can use it effectively.
Let's walk through the acronym, starting with R, rapport, and reflective listening. Which, sounds obvious, but I'm guessing you can't just sprint up to someone in shock with a clipboard and start asking them questions.
No, please don't do that. Establishing a supportive, compassionate presence is the absolute prerequisite for everything else. And the guidelines provide very specific techniques.
Like what?
First, you have to minimize distractions. If there are sirens, big crowds, or chaotic noise, you gently move the person to a quieter space if it's possible. Then you introduce yourself clearly and state your purpose. My name is David, I'm with the response team, and I am just here to listen and help.
Keep it super simple. And the text highlights a crucial distinction here, which I found fascinating, determining if the person is leading with their head or their heart.
This is a vital piece of reflective listening, because you have to meet the person exactly where they are. If a person is in a cognitive space leading with their head, they will be asking rapid-fire questions. What happened? Where is my family? How did the fire start? They are desperately trying to logically assemble a fractured reality.
So if they are in that analytical space, you shouldn't suddenly put your hand on their shoulder and ask, how is your heart feeling right now?
No, doing so would be incredibly jarring, and it could actually break trust. If they are seeking cognitive information, provide clear, factual answers to the very best of your ability.
And if they're leading with their heart.
Conversely, if they are weeping, expressing profound fear, or even nonverbal ever, they don't want logistical data. They need emotional grounding. You have to validate their emotion first. Over time, the goal is to gently guide them from the emotional extremes back to a cognitive center, but you must start on their territory.
Okay, that makes perfect sense. Once you have established that rapport, we move to A assessment. Now, the sources emphasize repeatedly that this is not a clinical diagnosis. You aren't trying to figure out if they have generalized anxiety disorder.
Right, it's a practical appraisal based on a cognitive, emotional, behavioral, spiritual, and physiological signs. You're essentially observing them to screen for a need. Is there evidence that this person requires intervention? And if so, you appraise the severity of their dysfunction.
But wait, I have to push back here. How can we ask an ordinary person, a teacher, a retail manager, a neighbor, to perform a quote-unquote psychological triage? If I don't have a medical degree, how do I avoid misdiagnosing someone's reaction?
It's a fair question.
Because what is the functional difference between noticing someone is in distress versus noticing they are actually experiencing dysfunction? If someone's house just burned down, extreme distress seems completely 100% appropriate.
And that is the pivotal distinction in the assessment phase. Distress is the expected, painful emotional reaction to trauma. Crying, yelling, shaking, expressing anger at the universe that is distress. It is deeply uncomfortable to witness, but it is not necessarily incapacitating.
It's just the brain doing its job.
Exactly. Dysfunction, however, means the person's ability to attend to their basic fundamental responsibilities for themselves or others has been severely compromised.
Give me an example of what that looks like on the ground.
Okay, imagine a severe car accident. A mother is sitting on the curb. She is weeping uncontrollably, but she is holding her toddler tightly and moving out of the way when paramedics ask her to. She is in acute distress, absolutely, but she's functional.
Right, she's still protecting her kid.
Now imagine another person at that exact same accident. They are not crying at all. They are staring blankly into space, and they are aimlessly wandering back into the flow of active traffic, completely unresponsive to people shouting at them.
Wow. They have completely lost the ability to protect themselves.
That is dysfunction. They cannot process simple instructions, and they cannot recognize immediate physical danger. Dysfunction is the absolute inability to adapt and survive in that precise moment. That is who requires immediate intervention.
That clears it up immensely. The wandering into traffic example really cements it, and that flows perfectly into prioritization. If you are on the scene of a broader crisis with multiple people affected, who gets your attention first?
Prioritization relies heavily on Maslow's hierarchy of needs. Biological and physical safety always trump psychological needs. You cannot administer psychological first aid to someone who is actively hemorrhaging or someone standing in a structurally compromised building. You secure physical safety first.
Always. But once physical safety is secured, the text outlines what they call a crisis triad. These are the three massive red flags that push someone to the absolute front of the psychological triage line.
Right. The crisis triad represents severe psychological instability. The first indicator is behavioral impulsivity. This is the person acting recklessly, perhaps trying to run back into a burning building to save a totally replaceable object.
Like risking their life for a laptop.
Exactly. The second is diminished cognitive capabilities. They literally cannot compute the consequences of their actions. They are highly disoriented.
And the third.
The third is an acute loss of future orientation, which presents as profound, immediate helplessness. If you observe someone displaying this triad, they are your highest priority because they are in active danger to themselves or others.
Okay, so we have built rapport, assessed for dysfunction, and prioritized the most urgent individuals. Next up is I am intervention. We have recognized the problem. Now we take action to actually mitigate the distress. The Rapid model uses specific mechanisms of action here, like explanatory guidance and anticipatory guidance.
Explanatory guidance circles right back to the expectancy principle we talked about earlier. It is the act of calmly explaining to the person why their body and mind are reacting the way they are.
Giving them the context.
Yes. Helping them understand that their hyperventilation or their inability to remember the last 20 minutes is a known physiological stress response. It takes the terrifying mystery out of their suffering.
And anticipatory guidance is projecting that forward.
Exactly. It is preparing them for what will happen when the adrenaline wears off. You might say, listen, in a few hours, you are probably going to feel a level of exhaustion you've never felt before. You might not be able to sleep tonight, and you might feel nauseous. That is completely normal.
So by forecasting these symptoms when the person experiences them later that night, they don't panic.
Right. They think, oh, the first responder told me this would happen. It provides an anchor of predictability in a very chaotic time.
The sources also mention cognitive reframing as an intervention tool. Now, this isn't about toxic positivity, right? It's not telling someone who just lost everything to, look on the bright side.
Oh, definitely not. Toxic positivity invalidates trauma. Cognitive reframing is much more subtle. It's helping someone shift their rigid focus from absolute despair to a slightly wider perspective. If they are fixated on a total loss of property, gently acknowledging that their family survived, it's helping them find a tiny foothold of control in an uncontrollable situation.
And finally, we reach disposition. We've stabilized the immediate crisis, so disposition answers the question, what happens next?
Disposition is the handoff. The goal of PFA is not to become this person's long-term therapist. You are simply a bridge. Disposition might mean reconnecting them with their family or a trusted friend, what the military calls buddy care.
Or referring them out.
Yes, if you have gone through the rapid steps and the person remains highly dysfunctional, disposition means facilitating a referral to higher-level professional psychiatric care or emergency services.
Now, rapid is the model our sources focus on most heavily because it is so well structured for laypeople. But it's important to acknowledge there are other frameworks in the literature, and they all seem to share similar DNA.
They really do. For instance, there is the ABC model, which stands for Achieve Rapport, Boil Down the Problem, and Cope. It's a highly condensed version, often used in brief telephonic crisis lines. Then there's Roberts' 7-stage crisis intervention model, which is much more clinical, focusing heavily on exploring alternatives and developing action plans.
The sources also mention Lerner and Shelton's 10-step protocol and the SAFER R model.
Yeah, SAFER is widely used in emergency services. It stands for stabilization, acknowledgement of the crisis, facilitate understanding, encouragement of adaptive coping, recovery, and referral. So while the acronyms change, the underlying philosophy is identical across all these models. Establish safety, build empathetic connection, assess functionality, normalize the reaction, and build a bridge to long-term support.
That tactical response is incredibly effective when you are dealing with adults experiencing acute external shock. But looking at our research stack, the rules of engagement have to shift significantly when the crisis is internal or when we are dealing with vulnerable populations.
Well, an acute natural disaster is a shared external event, but chronic mental health struggles are highly individualized internal crises. To intervene effectively here, we have to understand how psychological stress manifests long-term. And the literature generally divides these responses into two broad categories: internalizing disorders and externalizing disorders.
Internalizing disorders feel fairly self-explanatory. The distress is directed inward.
Exactly. The individual essentially absorbs the psychological pain, leading to social withdrawal, profound loneliness, clinical depression, and severe anxiety disorders. The turmoil is contained within the self, which often makes it much harder for outsiders to detect until it reaches a critical mass.
Externalizing disorders, on the other hand, take that internal pain and essentially weaponize it against the environment.
This is where we see disruptive behaviors, aggression, impulsivity, and conduct disorders. The individual is essentially acting out the chaos they feel inside. And when people, particularly young people, lack the tools to process either of these states, they frequently turn to maladaptive coping strategies.
The most prominent being substance abuse and self-harm.
Yeah. These are desperate attempts to self-medicate. Substance abuse attempts to numb the hyperarousal of trauma, while self-harm is often used to externalize an unbearable internal numbness, literally giving the psychological pain a physical, controllable location on the body.
This is where the power of the community becomes vital. Our sources highlight the profound impact of spiralized self-help and support groups, specifically for populations facing intense societal stigma or complex trauma, like survivors of domestic violence or individuals living with HIV.
Because the most dangerous component of chronic trauma is isolation. It's the belief that no one can possibly understand what I'm going through. Community support groups completely shatter that isolation. Being in a room with people who have walked the exact same agonizing path provides a level of validation that a clinician simply cannot offer. It is a powerful antidote to both internalizing withdrawal and externalizing aggression.
Speaking of complex interventions, we need to spend some time on how we approach children in crisis. Intervening with kids is not just, doing adult therapy with smaller chairs and a softer
Not
voice.
at all.
The pediatric psychology sources outline an absolute ethical minefield for clinicians, which they categorize as the 5 C's of ethical challenges. Let's dive into those.
Okay, the first C is competence. A clinician must know the strict limits of their training. Working with a child is never a one-on-one dynamic. It is essentially a forced multiple relationship.
Because you aren't just treating the child, you're treating the parents, dealing with the school system, and potentially navigating social workers.
Exactly. If a clinician is not specifically trained in systemic family therapy, attempting to treat a child in a vacuum can cause significant disruption to the entire family unit.
That makes sense.
The second C is consent, which introduces massive legal and ethical gray areas. At what age is a child actually capable of consenting to their own mental health treatment? The literature debates the concept of mature minors, typically adolescents between 14 and 16 years old.
Because chronological age does not always match emotional maturity or the cognitive ability to understand medical consequences.
Which bleeds directly into the third and often most agonizing C, confidentiality.
Yeah, this seems like an impossible tightrope. On one hand, a teenager isn't going to tell a therapist anything real if they think the therapist is just going to call their parents immediately after the session. Absolute privacy seems essential to build trust and allow the adolescent to develop autonomy.
But on the other hand, parents have a profound legal, moral, and biological right to know about the health and safety of their child. Balancing the adolescent's need for a private therapeutic space against the parent's right to protect their child is incredibly difficult.
And the fourth and fifth C's just sort of pour gasoline on that fire. The fourth is competing interests. This usually manifests during acrimonious divorces or custody battles where parents might attempt to weaponize the child's therapy.
Yeah, a parent might bring a child to therapy not to heal the child, but to obtain clinical notes that prove the other parent is unfit.
Which is awful.
It is. And the fifth C is child maltreatment. Mandatory reporting laws dictate that if a clinician suspects abuse, they must break confidentiality and report it to the state. Doing so is legally and morally required, but it almost universally destroys the therapeutic alliance they have built with the child, who may feel profoundly betrayed.
The text provides a scenario that really illustrates how these C's collide. Let's look at Emily. She is 14 years old, and her parents are going through a vicious divorce. Her mother brings her to a counselor, but up front, the mother asks the counselor to write a formal letter for the court stating that the father is an angry man.
And right there, we see competing interests. The mother is attempting to utilize the therapist for her own legal strategy, compromising the therapist's neutrality before Emily even sits on the couch.
But the scenario gets much heavier. The therapist actually manages to build a rapport with Emily. After a few sessions, Emily confesses that she is planning on having sex with her 15-year-old boyfriend, and she also admits that they regularly smoke marijuana. But Emily begs the counselor not to tell her mother. She says her mother is already incredibly stressed from the divorce and would freak out and make her life miserable.
It's a classic dilemma.
It is, and I have to challenge the idea of absolute confidentiality here based on this text. If the therapist honors Emily's request to protect the trust they've built, aren't they potentially putting a 14-year-old in developmental or even physical danger? At what point does absolute confidentiality become professional negligence?
That is the exact dilemma that keeps pediatric clinicians awake at night. The literature is very clear that while privacy is crucial for adolescent differentiation, secrecy can be lethal. When an adolescent engages in high-risk behaviors that demonstrate poor impulse control and potential for severe harm, the clinician simply cannot just sit on that information. The risk to the child outweighs the sanctity of the therapeutic alliance.
So how do you handle that without completely traumatizing the teenager who finally trusted an adult?
Researchers strongly advocate for what's called a risk-aversive approach. This is a structural solution. It means that before therapy ever begins, you hold pre-treatment family meetings. The therapist, the parents, and the child sit down together, and the therapist explicitly establishes the limits of privacy.
So you draw the lines in the sand before anyone steps on the beach.
Exactly. You agree, preferably in writing, on what specific disclosures will trigger a breach of confidentiality. You might say, Emily, whatever we talk about is private. Unless you tell me someone is hurting you, you are planning to hurt yourself, or you are engaging in severe substance use that threatens your health. If that happens, I have to bring your parents in.
That's incredibly clear.
Because you define the boundaries before the crisis hits, If the therapist eventually has to tell the mother about the drugs, Emily might be angry, but she knows the therapist isn't maliciously betraying her. The therapist is simply executing the rules they all agreed upon.
Setting the terms of engagement up front preserves the integrity of the relationship. Now, that works for a 14-year-old who can articulate complex thoughts. But how do we reach younger children? A 6-year-old experiencing trauma isn't going to, recline on a leather couch and unpack their existential dread.
No, they don't have the cognitive architecture or the vocabulary for that. This is where the sources transition to the beautiful, complex world of play therapy. Dr. Gary Landreth, one of the pioneers in this field, famously summarized the philosophy by saying, "Toys become the child's words and play their language."
So by creating a meticulously designed safe space with very specific types of toys, children can project their internal chaotic conflicts out into the physical world where they can manipulate them.
Yes, and the curative factors of play therapy are deeply fascinating. For instance, there is direct and indirect teaching. Through storytelling with dolls or puppets, a therapist can enter the child's fantasy world and gently suggest alternative solutions or coping mechanisms. There is also simple catharsis, allowing a child to aggressively pop balloons or pound clay to physically release pent-up emotional energy in a totally safe environment.
But the concept that really stuck with me in the text was abreaction?
Oh, abreaction is profound. It is the process where children repetitively reenact a horrific trauma in order to gain a sense of mastery over it.
The pediatric papers noted this heavily after 9/11. Therapists observed children spending hours repetitively building massive towers out of wooden blocks, and then taking toy airplanes and violently crashing them into the towers, over and over and over again.
To an adult walking into that room, it looks deeply disturbing. You might think the child is obsessing over the trauma or that it's unhealthy, but neurologically, it is the exact opposite. It is the child's brilliant way of mentally digesting an incomprehensible horror.
Because they're in control of it now.
Exactly. The real event made them feel entirely helpless. By recreating it in miniature, they control when the plane crashes, they control how the blocks fall, and they control when the game stops. They are literally shrinking the trauma down to a size their brain can process.
There is also stress inoculation, where a therapist uses medical kits and dolls to rehearse a scary upcoming event, like surgery. You make the terrifyingly strange hospital environment familiar through play, inoculating them against the panic. But the mechanism that truly blew my mind is counter-conditioning.
Counter-conditioning operates on a core physiological principle. Two mutually exclusive internal states of arousal cannot exist in the body simultaneously. You literally cannot be in a state of terror and a state of genuine joy at the exact same time. The nervous system simply won't allow it.
So the text gives the example of a child who is debilitatingly terrified of the dark. Instead of just talking to them about why the dark is safe, the therapist brings the child into a dimly lit room and initiates a highly engaging, joyful game of hide-and-seek with a flashlight.
Right. You are intentionally pairing the stimulus that causes fear, the darkness, with a powerful positive effect, joy and playfulness. By repeatedly pairing these, the positive emotion literally overwrites the negative neurological association. You aren't just rationalizing the fear away, you are curing it at the level of the nervous system.
It is elegant, applied neuroscience. It really is. We have navigated the chaos of natural disasters, and we've walked through the complex ethical and developmental mazes of childhood trauma. But we have to turn now to what our research stack universally frames as the most acute, dangerous, and high-stakes internal crisis a human being can face: suicide.
It is the ultimate crisis.
Right.
To really understand the gravity of it, we have to look at the epidemiological data. Suicide is the 14th leading cause of death worldwide. It is responsible for roughly 1.5% of all global mortality.
Which is a staggering number of people.
Researchers like O'Connor and Knock point out what makes suicide so uniquely challenging to prevent. Unlike cancer, heart disease, or accidents, suicide is a cause of death directly driven by conscious decision-making and deeply complex psychological factors.
But because it is a conscious decision, it also means there is a window where it can be intercepted. The literature details the zero suicide model, which is a comprehensive framework being adopted by major healthcare systems right now.
The zero suicide model is built on three foundational pillars. First, our core values. This requires an institutional, cultural shift to genuinely believe that suicide can be eliminated among patients under care. It outright rejects the fatalistic notion that if someone really wants to do it, they will.
And the second pillar?
The second is systems management. This involves creating a continuous, unbroken chain of care where no patient is ever lost in the transition between departments. And the third is evidence-based clinical care, utilizing standardized, rigorous assessment tools.
And the urgency of this model is really highlighted by findings from the Joint Commission, which tracks sentinel events. These are unanticipated events in a healthcare setting resulting in death or serious injury. They found that the most common root cause of a patient dying by suicide while under the care of a hospital was the simple, tragic failure of the staff to adequately assess for suicide risk in the first place.
Patients slip through the cracks simply because no one asked the right questions at the right time. To properly assess risk, we have to understand the intricate interplay between risk factors and protective factors.
Let's break down risk factors because the text makes a critical point. They are not just a simple checklist where you add 1 point for each symptom. They are synergistic.
Synergistic means the combined effect is vastly greater than the sum of their parts. For example, a patient presenting with severe clinical depression has a statistically elevated risk of suicide. A patient presenting with a painful chronic medical illness also has an elevated risk.
Okay.
But a patient who has severe depression and a chronic medical illness does not just have double the risk. The risk multiplies exponentially because the two factors feed off each other, essentially destroying the patient's hope for a pain-free future.
These factors are further divided into chronic and acute. Chronic factors are the historical anchors that you cannot easily change. A family history of suicide, a history of severe trauma, or, and the sources emphasize this heavily, a personal history of past suicide attempts.
Past behavior is always the strongest predictor of future behavior. A history of multiple previous attempts drastically elevates the baseline risk for the rest of that individual's life.
Acute factors, on the other hand, are the immediate volatile triggers. The sudden loss of a job, a catastrophic public humiliation, a messy divorce, sudden social isolation, or a spike in impulsive aggression.
And to make sense of all these overlapping factors, clinicians don't just guess, they use structured algorithms. The text details the PCBH algorithm as a primary example of how to classify risk into 4 distinct tiers.
Let's walk through those tiers.
The PCBH algorithm forces the clinician to look objectively at ideation, plan, and history. Low-risk classification means the patient has no recent suicidal ideation and has fewer than 2 past attempts in their lifetime.
Okay, that's the baseline.
Moderate risk means the patient is experiencing recent suicidal ideation, but they do not have a specific plan on how they would do it. Or they don't have current ideation, but they have a history of 2 or more past attempts, which keeps their baseline elevated.
And high risk.
High risk is deeply concerning. This is a patient with recent ideation and a specific plan, though they have not taken any steps to prepare for it yet. Or it is a patient with ideation, no specific plan, but a history of 2 or more past attempts.
And then there's imminent risk.
Finally, yes, imminent risk. This is a psychiatric emergency. This is recent ideation, a specific lethal plan. A&E, they have engaged in preparation or practice behaviors like buying a weapon or hoarding medication.
Okay, I need to stop here and ask a deeply pragmatic question based on the text. The research acknowledges that the base rate of suicide in the general population is actually very low. Statistically speaking, the vast, overwhelming majority of people who experience a messy divorce, lose their job, and suffer from depression will never die by suicide.
But that is statistically true, yes.
If the math makes it so statistically unpredictable on an individual level, how can anyone, a layperson or even a highly trained psychiatrist, know when someone is actually going to act? The false positives must be enormous.
The false positive rate is enormous, and that is the agonizing paradox of suicide prevention. Because the event is mathematically rare but the outcome is fatal, relying on clinical intuition or a gut feeling is incredibly dangerous. Gut feelings are inherently subjected to our own biases.
Right, like we see what we expect to see.
Precisely. A clinician might subconsciously minimize a patient's pain because the patient is well-dressed and articulate, or they might overreact to a patient who is just highly emotionally expressive but not actually suicidal. That is precisely why structured risk assessment algorithms are non-negotiable. They remove the guesswork and the emotion from the evaluation.
So the algorithm forces you to look at the facts.
It forces you to systematically weigh the lethality of their proposed plan, their physical access to the means, and their historical data. It dictates a standard protocol of action based on hard data, ensuring that you don't underreact to a quiet patient who is actually at imminent risk.
So the algorithm is your anchor in the storm. Let's assume you have run the assessment. whether formally in a hospital or informally as a concerned friend, and you realize you are in the danger zone. The immediate next step is intervention. How do you actually talk to someone who is standing on the brink?
Everything begins with direct, unambiguous communication. The literature stresses that you cannot dance around the subject. You use a hierarchy of screening questions that gently but firmly funnel down to asking the direct question, are you having thoughts of ending your life?
I think the universal fear for anyone who isn't a trained professional is that by asking that question so directly, you might accidentally plant the idea in their head.
That is one of the most pervasive myths in mental health, and the research resoundingly debunks it. Asking directly does not cause suicidal ideation. In reality, it almost always provides profound relief.
Relief.
Yes. The person has been carrying this terrifying, isolating secret, and by asking the question, you show them that you are not afraid of their pain. You are willing to step into the darkness with them.
Clinicians use very specific screening tools to facilitate these conversations in emergency rooms and primary care offices. The sources list several: the SAD Person Scale, the PHQ-9, the Columbia Suicide Severity Rating Scale, or CSSRS, and the Beck Hopelessness Scale.
These tools are designed to measure intent and severity quickly. The Beck Hopelessness Scale is particularly important because the research identifies hopelessness, the absolute conviction that the future will never improve, as the primary cognitive factor mediating the relationship between depression and suicidal intent.
Because you can be profoundly depressed, but if you still have a sliver of hope that a new medication or a change in circumstances will help, you are less likely to act. When hope dies, the intent crystallizes.
Exactly. And once that intent is detected, intervention must occur in that exact same visit. You cannot tell an imminent risk patient that their therapist can fit them in next Tuesday. Immediate intervention requires safety planning and lethal means reduction.
I was really trying to conceptualize means reduction while reading the sources, and it feels like a bridge. Imagine someone in the deepest, most agonizing despair is standing on one side of a massive chasm. On the far side of the chasm is hope, recovery, or just survival.
I like this visualization.
You cannot simply stand on the far side and yell at them to jump across the gap. They don't have the psychological strength to make that leap. When someone decides to end their life, they begin building a bridge into the abyss. Means reduction is the process of working collaboratively with the person to physically remove their access to the method they intend to use.
Whether that's temporarily storing firearms outside the home, locking up medications, or changing their environment entirely.
Right. It is like throwing up a massive concrete barricade on the bridge they are building.
Yeah.
It doesn't magically teleport them to the side of hope. So what is it actually achieving in that critical moment?
It achieves the single most vital element in crisis intervention. It buys time. We know from extensive study that suicidal urges are intensely powerful, but they are also highly transient. They operate like a wave, they peak, and eventually they subside.
So if a lethal method is immediately available during that peak wave of impulse,
For instance, a loaded firearm in the nightstand. The transition from the thought to the fatal action can occur in a matter of minutes. The urge doesn't have time to pass.
but the barrier removes the immediate option.
By physically removing the means, you force a delay. You force the brain to pause, to figure out an alternative method, and in that enforced delay, the intense wave of impulsivity often breaks. The urge subsides just enough for the person to reconsider, or for the psychological first aid, the medication, and the social support to actually begin working. You are literally buying the time necessary to save their life.
That is a profound way to look at it. You are buying time for the wave to pass. And speaking of time, we have to recognize when the danger is statistically at its highest. A layperson might assume the highest risk is right before someone is admitted to a psychiatric hospital. But the data points to a terrifying reality post-discharge.
The first 28 days following discharge from a psychiatric inpatient facility is a period of staggeringly elevated risk for suicide. It is the most vulnerable period in the entire continuum of care.
Why is that? I mean, they just received intensive treatment.
It is the shock of the reentry phase. Inside the inpatient facility, the patient is constantly monitored. The environment is perfectly physically safe, and they are isolated from the specific stressors that triggered their crisis.
They're in a bubble.
Discharging them means taking them out of that protective bubble and dropping them back into the exact same environment, the same family dynamics, and the same financial stressors that precipitated their crisis in the first place, often without a constant safety net.
The contrast is just overwhelming.
This data highlights the absolute necessity for rigorous, unbroken follow-up care. A hospital cannot just hand a patient a discharge paper and wish them luck. There must be clear reentry pathways, immediate outpatient appointments, and a concerted effort to wrap the patient in a robust community and family support system during that critical first-month transition.
We have asked you, the listener, to absorb some incredibly heavy, intense tactics today. We've gone from managing mass casualty disasters with the Rapid model to navigating the heartbreaking ethics of child abuse reporting to literally throwing up barricades to prevent someone from ending their own life.
It is a lot to process.
It is.
Yeah.
And absorbing other people's trauma, standing with them in their darkest moments, takes an immense, sometimes crushing toll on the person providing the help. To sustain this work, to actually be useful when the alarm sounds, we must finally talk about the person in the mirror. We have to talk about healing the healer.
The literature universally recognizes what is known as the cost of caring. Crisis interventionists, whether they are veteran first responders, clinical psychologists, or just a neighbor helping after a flood, are at a very high risk for developing vicarious trauma.
It's important to define that because vicarious trauma is not a sign of personal weakness.
Not at all. It is a completely normal, expected neurological and psychological reaction to absorbing abnormal, horrific events. You cannot repeatedly expose your empathetic nervous system to human suffering without it leaving a mark.
The danger is that this exposure leads to burnout, professional isolation, and a profound emotional exhaustion. Over time, hearing horrific stories day in and day out begins to shift your own worldview. You start seeing danger around every corner. You become cynical, hypervigilant, and disconnected from the joy in your own life.
To combat this institutional hazard, professional organizations employ structured debriefing systems like PASS post-action staff support. This is a vital protocol where PFA providers sit down with experienced peers immediately after a deployment or a particularly heavy intervention.
So they process it together.
And it's important to note that PASS is not just casual venting. It is a structured review that checks 3 specific domains.
Let's walk through them. First, the operational check. Did you follow the rapid steps? Did you execute the protocol correctly, or did you miss something in the assessment phase?
Right.
Second, the clinical check. Did you navigate the emotional domains correctly? Were you able to guide the person from a cognitive state to an emotional state and back again without losing control of the interaction?
And third, and undoubtedly the most important, the personal check. How are you doing emotionally? Did this specific intervention strike a personal chord? Did the victim remind you of your own child?
The PASS system forces the intervener to process their own reaction before it calcifies into vicarious trauma. But beyond institutional support, the clinical guidelines heavily emphasize strategies for personal self-care outside of the professional environment.
They break it down into categories. There is physical health, which sounds basic, but is the foundation of resilience. Strict sleep hygiene, hydration, cardiovascular exercise to burn off residual cortisol.
Then there is social support. Intentionally spending time with family, engaging in your own individual psychotherapy, and seeking peer consultation.
And finally, spirituality or meaning-making. Finding ways to practice active gratitude, spending time in nature to reset the nervous system, and actively reframing the ultimate meaning of the grueling work you are doing.
Now, looking at this list, I really think it's necessary to challenge how modern culture talks about self-care. Because right now, the phrase has sort of been hijacked. Self-care sounds like a marketing buzzword for buying a scented candle, taking a bubble bath, or treating yourself to an expensive dinner.
It's framed as a luxury.
Exactly. But reading these clinical guidelines on trauma, we need to completely reframe what self-care actually is. It is not a luxury, it's an operational necessity. Think about it like a scuba diver.
Okay, a scuba diver.
If a scuba diver is preparing to dive into rough waters to save a drowning swimmer, taking the time to check their own oxygen tank, ensuring their regulator is functioning, and checking their buoyancy compensator is not a luxury. It is not them being selfish.
Because if they dive in with faulty equipment
and run out of air, they don't save the swimmer. There are simply now 2 drowning victims for someone else to rescue. Self-care is checking your oxygen tank before you dive into someone else's crisis.
That analogy perfectly captures the clinical reality. If your psychological reserves are depleted, your cognitive capabilities diminish, your patience thins, and your ability to maintain that vital, compassionate presence, The core of the Rapid model
You
shatters.
can't give what you don't have.
You absolutely cannot provide expectancy. You cannot normalize someone else's internal chaos if you are internally chaotic and exhausted yourself. Taking care of your physical, social, and spiritual health is the non-negotiable maintenance required to keep the tool, which is you, functional and ready to deploy.
So let's take a deep breath and look back at the map we have drawn together over this deep dive. We started on the bloody battlefields of Solferino and the ashes of the Coconut Grove fire, tracing how the realization that the mind breaks, just like the body, birthed the modern concept of psychological first aid.
We unpacked the profound impact of the PIE principles: proximity, immediacy, expectancy, proving that immediate normalized intervention heals the psychological fracture before it sets crooked.
We walked step by step through the tactical application of the Johns Hopkins Rapid model, learning how to build rapport, assess the critical difference between distress and dysfunction, prioritize those in the crisis triad, intervene, and build a bridge to long-term disposition.
We navigated the profound ethical complexities of treating vulnerable children, balancing the absolute necessity of privacy against the life-saving requirement of mandatory reporting, utilizing risk-aversive approaches to protect the therapeutic alliance.
We explored the astonishing mechanisms of play therapy, where children rewrite their neural pathways through abreaction and counter-conditioning.
We confronted the stark mathematical realities of suicide prevention. We learned that because the base rate is low, we cannot rely on biased clinical intuition. We must use structured algorithms to identify synergistic risk factors.
We explored the critical necessity of immediate intervention and how means reduction acts as a physical barrier on the bridge to the abyss, buying the precious, life-saving gift of time.
And finally, we established that self-care is not a spa day. It is the operational oxygen tank required to survive this work.
It is a massive, comprehensive toolkit.
Yeah.
And while we genuinely hope you never have to use any of it, the statistical reality of being human is that crises will eventually occur in your orbit. But having this conceptual framework means you no longer have to be paralyzed by the fear of the invisible wound. You have a structure to lean on.
You don't have to freeze.
Exactly. Imagine again that sudden crisis unfolding in front of you. The disaster strikes, the bad news is delivered. But this time, when you step forward, you don't freeze. You know to minimize distractions. You know to introduce yourself calmly and determine if they are in their head or their heart. You know how to assess for true dysfunction. You are stepping into the muddy waters with a map. But as we close this deep dive, I want to leave you with one final provocative thought to mull over. We spent all this time talking about how you can intervene in someone else's crisis. Turn that lens inward for a moment. Look at the architecture of your own world. Who is in your social support network right now? If the worst happened to you and you hit that terrifying disillusionment phase of a crisis tomorrow, who are the people that would act as your psychological first responders? Maybe today is the day to reach out to them, not because you are in crisis, but simply to strengthen the bridge before you ever need to walk across it.